Next up, we have
All right. So again, I think when Ben was sitting down, he's like, ideal PAO. It's like, well, we have Keith Mayo, Joel Matta, Mike Stover, Rob Wetzel. He can tell us what the ideal PAO correction is. So I'm going to do my best to go through some different cases and different techniques and just what I've learned over the couple years. But like, seriously, ideal? Are you kidding me? I'm not sure. I don't think anyone really knows, and you try to match it to each patient and try not to stick to dogmas with exact numbers and exact positions for everyone. So I'm going to go through some of my cases first. Okay, this is a recent case. Hypermobile patient, not Ehlers, but like in that hypermobile zone. She still had some posterior instability type symptoms after the right side at 38, and I was like, you know what? I'm going to correct her a little bit more on the left because she was still having some apprehension and deep flexion. She was okay with it. She didn't want a revision. But then I went on and did her left. Absolutely hates it. I was like, this is what I was trying to prevent in you. So I thought I knew what I was doing. And this is not a good x-ray, but she's now, this is a supine recent x-ray. I had to revise her to actually take out some of that version, give her a little more anterior coverage. So still learning some of these things. This is another patient of mine who I think is 3 and 4 years out, right and left. 3 years out, 4 years out from this side, the right side, and 3 years out from the left. Now she comes in, just back to her activities, doing all right, and she's like, man, my left side is perfect, but my right side, I don't really know. And if I'm looking at it, I can see what she means. Like it's 2 degrees difference by measurement, like 2 degrees. If you look at it, you can just kind of tell there's a little more posterior coverage on the left, a little more kind of reciprocal stability, maybe looking at that. I know hot topic, hot word today, but by numbers, sometimes it's like just 2 degrees really matter. Well, sometimes there's a threshold, and sometimes you have to figure that out, and sometimes that's really hard. But for each patient, I think this is really a challenge that we go through with each one of these operations. So that's why maybe intraoperative range of motion examination is important. Trying to figure out maybe what for each different person is more important. Is it lateral coverage? Is it posterior coverage? What's the reason you're there? Is it hypermobility? Is it truly a mix of borderline dysplasia and FAI? Is it severe dysplasia? So when those things are happening, trying to figure out what you're going to focus on for each of those specific pathologies. Okay. So here's another case I put up there without obvious dysplasia, but I think this group probably sees what's kind of going on. But this is a very hypermobile, high Baton score patient, like 5 out of 9, maybe not very, but hypermobile in some regard. Good relief with diagnostic injection, all the typical kind of physical exam findings that you would see. And then if you go through and measure her lateral center edge angle, it comes up about 27. Okay, and you can see on MRI that she has an anterior labral tear as well. This is a case from several years ago, at least in my practice, probably like 7 years ago. First, so she underwent an arthroscopy for labral repair and osteoplasty. So typically in Cleveland, we'll see either my partner or myself, we go through your options and they pick sort of what to do, present them with everything that's out there. We typically will guide patients to combo procedures, especially if they have clear pathology. This patient was like, listen, I don't want to go through a big operation, I just want to have a scope. She goes through a scope, she has good restoration of head neck offset. And then in the scope, you see this traditional or this kind of classic posterior stripe wear, maybe signs of instability, the superior lateral overload of the or the chondral junction in the superior lateral area, signs that show that the hip is moving in maybe ways it shouldn't. So signs of maybe intraoperative instability. So we go back and talk to her and say, hey, listen, I think you're going to need a PAO. And this particular case, sparked us to change at least how we think about some of these things, especially with the lateral anatomy of the sourceal. And if you look at her anatomy, sometimes the traditional numbers, and this is sort of the point of this case, like I started off with, maybe the numbers matter, maybe they don't, but I think you have to look and see where the actual weight-bearing surface of the sourceal matches to the femoral head. And what we sort of called this, at least in Cleveland, is the PDC, point of divergence of congruity. So we look at actually the femoral head perfect sphere and translate that so that it matches the perfect arc of the socket. And where that starts to deviate, sort of similar idea as the alpha angle, where it starts to deviate sort of where you're losing that match of weight bearing. So looking at more of the functional position of the sourceal, functional position of the socket, where you're getting some reciprocal weight bearing area of the roof of the sourceal onto the femoral head. So that's what we've sort of based our correction on. And sometimes if you antivert that a little bit and rotate the socket, that up flaring lateral edge will actually come down and you'll get a really kind of quick and rapid increase of lateral weight bearing reciprocal nature of the acetabulum with a minimal correction. But in this case, it didn't. So I had to make sure that I was able to get that sufficiently lateral to put her in a normal range, and she was very stable after this and did very, very well after correcting her with the osteotomy. Another patient that came back, she was a very high Baten score. She's an Ehlers diagnosis, probably to Josh's point, probably overly diagnosed, but very, very hypermobile individual. So she comes in with a lateral center edge angle of 19, a lot of posterior symptoms, a lot of posterior instability. She's having a lot of posterior buttock pain, but it always starts with groin pain and then radiates that way. Has a positive apprehension test and a very significantly increased femoral anaversion angle of about 40 degrees. So she has excessive femoral anaversion. She also has this MRI finding of anterior stress reaction in her femur and a very narrow ischiofemoral space. So definitely some combined pathology, dysplasia, ischiofemoral impingement, and increased femoral anaversion. So her correction is a little bit different. I want to make sure, because she was having a lot of posterior apprehension, posterior pain, my focus was obviously to make sure that she doesn't end up with a center edge of still 19, increase her lateral coverage, but I wanted to make sure she got good posterior coverage. So I'm thinking anaverting her more in this particular case, especially since I'm going to be neutralizing her femoral version to try to get that combined version under control. So she had restoration of her head neck offset. You can see some findings too. We'll often see this dimpling or the crevasse sign, I think that Josh mentioned earlier, where you see some of that posterior instability. And she underwent labral repair and then followed by a PAO. So my goal here was really to make sure the posterior wall was coming around to cover almost about 10% less on her, or just leaving about 10% of her extrusion index left, and really getting a good wrap around of the posterior wall on the obturator view to make sure she had good posterior coverage just to treat her individual symptoms. And then I went on to do her femoral osteotomy. This is just my technique, nothing super special. I use a piriformis nail. I use a vent hole in the femur just to allow for intramedullary contents egress to prevent pressure-related injuries. And I'll start with a low-energy mechanism of osteotomy by doing drill holes, and then I've just had a couple with osteotomes that are probably dull, that cracked away the medial side, so I'll try to perforate it as much as I can with a drill bit, and then just kind of buzz it with a saw quickly and try to finish the last little bit of it. But I'll put the whole nail down first after I've reamed, so I can see where this fixation pattern is. And I try to keep it as high as I can or close to the isthmus, because I truly believe what Dr. Stover said earlier. If you're trying to make an osteotomy in the middle of an arced bone, you're going to get some translational deformity, or it's just not going to match up right. So I try to keep it higher up where the bone is a little bit straighter. And then I'll use a single pin X-fix with pins above and below and dial in that degree of correction, usually around 20 degrees and not more, to prevent any sort of patellofemoral issues from that rotation. And then I'll use the internal compression. You can see the number 2 and 4 pictures when you compress through the nail, how much difference you could see at the gap of the osteotomy. So for this particular patient, I wanted to make sure, I said, like, I got good posterior coverage, obviously didn't sacrifice on her lateral coverage, and then treated her femur as well. So when you do a lot of these and you're like in high volume and you really want to do like many in a day, and you hear a lot about that at these conferences about how many I can do and how, how a lot, you get lost sometimes in like the individualization of some of these corrections, which is easy to do. It's no criticism. But I think when I'm trying to think of the ideal correction, that's sort of what I'm focusing on, is like this individual person and their exam. One last example, this is more of a severe dysplasia, obviously break in Shenton's line, not too hypermobile, actually pretty stiff, but has an exam that's fairly typical, also with anterior and posterior pain. She definitely has some lateral escape there, as you can see, as well as the break in Shenton's line, as I mentioned. So this is a 27-year-old person. Her MRI wasn't too bad. And I was talking to Dr. Closey about this at the lunch break. Is anyone considering arthroplasty in this patient? Has anyone lowered their threshold for doing arthroplasty in like the young 30s, maybe late 20s with the advances in polyethylene? Anyone? So that's the question. All right. So he asked the right question. Their MRI actually showed not. They really don't have that much arthritis. To Shane's point during his talk, some of these cases when they come down the line, where they'll get sent to the joints guys, they say, hey, listen, they don't have arthritis. Well, then the scope guy says, hey, the labrum is diminutive. It's not going to be a great reconstruction. Maybe 27 is not a great example, but what about a 36-year-old with 3 kids at home? Are you going to do a PAO on that person? That's a tough question. So maybe that person's ideal correction is metal and plastic and ceramic. So just something to also kind of consider. So this patient, just to go by numbers, has almost a neutral center edge angle and really diminished posterior coverage, posterior wall sign evident, and a vertically oriented, essentially false profile view with no anterior coverage other than the spine. So this is going to be a pretty significant correction, kind of going into that, knowing that. Anybody scoping this? Previous talk kind of went through this. I think something this severe, most people are kind of shying away from the scope, even people that are frequent scope comboers. So no scope in this particular case for me as well. When I have to do what I would consider in my mind a serious correction, when I'm really focused on making cuts, I try to make the cuts a little less squared and maybe a little more round. And you ask yourself, well, why don't you do that every time? But just really focusing on particularly the orientation of the pubic ramus cut, making sure that the ramus is in an orientation that doesn't trap itself down. Sometimes even segmenting the ramus or taking a little, as Dr. Stover taught me, a little haircut off the top of either the ilium or the pubic again, just to make sure you have a really hypermobile segment. So I'm kind of going for as best a correction I can in this case. And I think anyone who's tried to maximize a correction knows that there's going to be a stop somewhere. You sometimes, and you have to realize this, that you can try to correct a thing as far as you can when you're doing these, but there's going to be a stop. There's going to be some tension in the soft tissues that prevents you from going a little bit further. But in a case like this, I would try to push it as far as I possibly can to try to really contain with good lateral coverage a hip that's this severely dysplastic. So in terms of ideal correction, sometimes it's just as much as I humanly possibly can. And I've never, in a case like that, in severe dysplasia, even come close to overcorrecting. So I was really happy with this particular case in terms of the correction. And her post-operative imaging maybe isn't as impressive as the fluoro, but she's done very well and has really had no complaints. She probably has an incomplete union of her ramus. And I've published my own series on that in about 7 or 8 cases, and there's usually a concomitant factor like smoking, obesity, DMARDs, some sort of autoimmune disease. This person, I think it was just distance of correction. So I think that in a severe case like this, when I see them in the office and I know that their correction is going to have to be serious and with a lot of translation, I'll usually tell them there is a chance you may have a pubic ramus non-union. It may or may not be symptomatic, and sometimes you'll see a concomitant inferior ramus stress fracture. You've probably seen that at some point if you do this operation. If the superior ramus doesn't heal, oftentimes we'll get a stress reaction or even a frank stress fracture of the inferior ramus. And in that case, that happens, and I usually will plate this with bone graft, but fortunately not so much for her. A couple just videos that I can narrate. So in order to get, I think, the most ideal correction, you should know your instruments well. I liked using this cannulated clamp that goes over a 5mm Schanz pin, and it has really aggressive teeth and a powerful ratcheting mechanism. So it's a significant, really powerful tool that I'm able to really correct in multiple planes. And I think as, like, let's say you're just getting into practice and just learning this operation, to really get comfortable in unlocking the ramus and getting more lateral coverage through rotation down this axis of this pin, that's probably the most challenging thing that was for me early on, trying to get that ramus unlocked and getting lateral coverage. Version is typically a little bit easier, which is just a medial lateral maneuver. And just one more video as I'm kind of summarizing this. As you're going through this, if you want to increase your lateral coverage, typically it's a rotation maneuver. Also can be some flexion or some oblique plane vector. The video is going to demonstrate a fragment that's stuck. I wasn't happy with this at all. And this goes back to one of the tools being my own table. So using the Guardian, you can pull some traction through there. Not much, a couple centimeters of traction, and it just unlocks all the planes of movement. So I was really happy with then after just pulling a little traction, getting it mobile, and sometimes after that traction's involved, you just feel it kind of give, and then you can let that traction back off. And you do want to try to check and make sure your pelvis is recentered and you didn't change anything when you're doing that. But these are the maneuvers that I've learned to what they respond, like your maneuver and how it translates to what it looks like on an x-ray. So if you want to add version, whether that's forward or backward, your flexion and medialization, which is really important. I think Dr. Matta earlier talked about leaving residual retroversion was one thing and lateralizing the joint center. I think that's definitely a mistake. If you go through a correction, even if you think you've done it right, and your joint center is lateralized, you need to revisit that and re-look at how you've made your correction and see if you can medialize the joint center to reduce that joint reactive force. All right, what's the future? Okay, so the future of corrections. So maybe if I don't know ideal corrections, maybe we can just plan ideal corrections. So maybe there's computer assisted, maybe there's navigation. This is just demonstrating the Medacta My PAO system that has these custom 3D printed arcs. Not so much custom cutting guides, but actually custom correction arcs. There's definitely pros and cons to the system, but it's just a step in the right direction with the future of actually trying to pre-plan what you would consider to be a perfect correction, which is no easy feat, even with planning, because we're used to looking at weight-bearing epipelvis x-rays, and then we look at 3D CT scans, but are those 3D CT scans matched in spinal pelvic tilt to the weight-bearing position of the pelvis? You have to understand what the functional position of the hip is. Is the answer what Mike and Robbie are looking at in Iowa with finite element and weight transfer and the joint reactive force? There's still a lot to learn in this space, which is what's really exciting, I think, about hip preservation in general. We were sort of making a joke at lunch. I was telling my co-residents, because we did residency here in Chicago, and it was 10 years this year, and I was like, hey, I'm in Chicago for this hip preservation summit, and one of my joints buddies was like, people still preserve hips? I'm like, come on, bud. He's like, because hip replacement is such a good operation, but there's still so much to learn about how to make these young patients with hip problems and cartilage problems and something that can really change their life now, but also change their life for 50 or 60 years. So I think it's a really exciting field. Last little pearls. So I'm a trauma guy by training, and think about like the Monteja fracture. You can't get the radial head in. They say ulnar length, number 1, number 2, number 3. It's always ulnar length. For me, early on, if you can't get the fragment to move, it's always been the pubic ramus. So revisit the ramus. Make sure you can unlock the ramus so you don't have to worry about that anterior portion of the fragment catching, and then it becomes a lot more mobile and free. But if you're going through, these are sort of some of the other tips that I've been given to myself from experts and mentors along the way. But I will say, try not to leave the operating room unless you're happy with your correction. Don't try to convince yourself it's okay or this is the best you can do. Take some time, revisit it, try to get it better, and I think this operation can truly change lives.